Mood disorders are, this chapter is going to be divided into major depression, bipolar disorder, seasonal affective disorder, cyclothymia, dysthymia, postpartum depression, postpartum psychoses, postpartum blues, and grief and depression. So let's start with major depression. A 70-year-old woman was recently admitted after her son informed the doctor that his mother had been doing very poorly. The patient reports a 30-pound weight loss, decreased concentration, feelings of helplessness, hopelessness, decreased energy, depressed mood, and decreased sleep. This is a woman who is suffering from major depression. How do we know that? What's essential of major depression is that you have to have the symptoms for more than 2 weeks. Not only do you have the symptoms, but these symptoms are severe enough to cause a deterioration in your level of functioning. Because of your mood, you're not going to work. Because of your mood, you're not eating. Because of your mood, you want to die. Because of your mood, you want to stay at home and not do much of anything. Because of your mood, you're not taking care of yourself, you're not taking care of your family, and all of your life is just crumbling down. That is what major depression is all about. For you to have the diagnosis of major depression, you also need to have either a depressed mood or an anhedonia. An anhedonia, of course, was absence of pleasure. If you recall this patient, the time frame is not there, but it's been a while since she's been doing that. And she definitely has the deterioration in her level of functioning, and she has the depressed mood and cognitive deterioration, as well as the problems with the helplessness, hopelessness, the weight changes, etc. As far as the risk factors and the etiology of major depression, you tend to find more major depression in women than you do men, and this is approximately 2 to 1. And there's various reasons for this. One could be basically the bias in the diagnoses. Women are more likely to be diagnosed with major depression than men. Men might be given a pat on the back, sent on their way, you're a big man, you can take care of everything, and they don't get proper treatment. Women tend to be perceived as more in need of care. Everyone is likely to give them medication, and therefore they get treated much more often than the men counterparts. Also, could it be hormonal? The hormones that women have are different than those of their male counterparts. So could these female hormones be the cause for major depression? And it's very possible. Also, the stress in women's lives are much different than the stress in men's lives. So these are the common reasons why you tend to find more depression in women than you do in men. The average age for depression is about 40. And you also see depression in those individuals who basically are alone. They have no family, they have no friends, they have no one to talk to, no one to share their problems with, and therefore they tend to internalize everything, and they're more prone to suffer from major depression. One of the most important theories of major depression is a neurotransmitter theory. So what you tend to find is decreased levels of either norepinephrine or serotonin or dopamine. So not only are these neurotransmitters implicated, but so are their metabolites, the most important of which will be the metabolite of serotonin, which is 5-hydroxyindoleacetic acid, or 5-HIAA. 5-HIAA, when you have low levels of it, it's associated with two things. This is a neurotransmitter that basically, a metabolite I should say, that tends to be disinhibiting. So when we're disinhibited, what are we more likely to do? Number one is that we're more likely to be aggressive, and number two is we're more likely to be suicidal. So aggression and suicide are the most common findings associated with low levels of 5-HIAA. Other risk factors include family history. Major depression is very genetic, so if your mother has it, grandmother has it, you are at increased risk of developing as well. Any stress could lead to major depression, and the most important environmental stresses could be either death of a spouse, so you're older, your husband or your wife dies, you're at increased risk for depression, or when you are younger and your parents died. If your parents died before the age of 11, your age of 11, that you as an adult are at increased risk for depression. Another theory for depression is mostly behavioral, and that is a concept called learned helplessness, which has been called the animal model of depression. If you're in a situation that you can't escape, you can't avoid, what do you tend to do? You're going to give up. And when you give up, that's when the depression sinks in. The essential features of major depression is that you're going to be depressed most of the day. It's very common for us to wake up and say, "Oh, I'm depressed today." But we're not depressed. We're just feeling sad. Because people with depression wake up depressed, stay depressed, go to bed depressed. They have this absence of pleasure or anhedonia all day long. The things that they thoroughly enjoyed, whether it be shopping, whether it be fishing, whether it be doing whatever, they don't seem to enjoy anymore, so they tend to stay at home. They're going to have weight changes. You're either gaining weight or you're losing weight, but what you're doing more frequently of is that you're losing weight. Why? Because you're having appetite changes, where you're either eating a lot or you're eating less. But what you typically find in depression is that you're eating less, so therefore you lose the weight. You also have sleep disturbances. Now, you either are sleeping a lot, so you stay in bed all day, or you sleep less, which means it's hard for you to fall asleep. When you do fall asleep, you wake up very early in the morning, or you wake up continuously during the night. And these are very common changes in depression. The sleep, the weight, the appetite. These patients also have psychomotor disturbances, where you might have psychomotor agitation, where you have restlessness, you can have some propensity towards violence, or you have the most common approach, which is the psychomotor retardation, the slowing down of the movements. You're just sitting there and you're not doing much of anything. You're going to get tired easily. You're going to feel worthless. You're going to feel guilty. You feel helpless. You feel hopeless. You will not be able to concentrate, so you cannot do any reading. You can't watch TV. You can't read the newspaper. And if you do, when you finish reading that article, you say to yourself, "What on earth did I just read?" Because you have no recollection whatsoever. And of course, the most important thing about depression is that 2/3 of these patients will have suicidal ideations, and about 10 to 15% of them will actually commit suicide. So major depression is a psychiatric disorder most closely linked to suicide. If you were to do a physical exam on these individuals, you probably will not find much of anything. You might see some slowing, some psychomotor retardation. You might find some problems with their speech, where they might be speaking very softly, very slowly. You might see the stooped posture, but otherwise you should not find any abnormalities, unless, of course, the patients are not eating and they're losing significant amounts of weight. If they have concentration deficits, what a lot of them do, then you'll see them having problems with the serial 7s. You'll see them having difficulties with the serial 3s. They won't be able to spell words backwards because of their concentration deficits. As far as lab tests, none of them are routinely done as a diagnostic basis, but a few of them do have some historical value. For example, the dexamethasone suppression test, or the DST, is usually abnormal in patients with depression. So what you do is that you give the patient dexamethasone in the evening, and the next day you measure the level of cortisol. What should occur is that dexamethasone, because it's a steroid, it will suppress the level of cortisol. However, in patients with depression, this will not occur. So you have an abnormal DST. Another common test is a thyrotropin-releasing hormone test. TRH should stimulate TSH. What happens in patients with depression is that you're going to get a different response. So you give the patient TRH, you measure TSH, and what happens? Instead of TSH going up, you basically find a blunted response. Now, these tests are not used routinely, but you should understand them because of the abnormalities that occur in patients who have the mood disturbances. Now, there's also certain types of major depression. One of them is a major depression with psychotic feature. This is the individual who definitely meets the criteria for depression. However, they could hear a voice. They could hear a voice telling them to hurt themselves. That would make it major depression with psychoses. Because psychoses is involved, you know that prognostically it's going to be worse. Treatment-wise, you have to be more aggressive, and you have to treat the psychotic symptoms before you ever treat the depressive symptoms. In reality, you treat both the depression and the psychoses at the same time. But if given the choice, as far as the severity, the psychotic symptom is worse, so you need to be very aggressive and make sure you stop the psychotic symptoms. If you do not treat the psychoses and only treat the depression, what will happen is that chances are the psychoses will worsen. Now, major depression with atypical features has also been called atypical depression, What's unique about this disorder is that you have what's called reverse vegetative changes. So these are patients who not only have the depression, but they have atypical changes. For example, sleep, weight, and appetite are the ones that are going to be most affected. So instead of sleeping less, you're sleeping a lot. Instead of having a decreased appetite, your appetite is increased. And instead of losing weight, you have increased weight. So that triad, that reverse vegetative triad, is what makes the depression atypical. And another clue for this is that these patients typically complain of having their limbs feel as if though they're made out of lead, or having their limbs feel very heavy. And that is a term called laden paralysis. And when you see that, that is also indicative of major depression with atypical features. Now, the treatment of major depression will be consisting of many things. The first thing we need to make sure of is, of course, that these patients are safe. These patients are not going to go out and kill themselves. So assessing suicide should always be the next thing that you do. If the patient is suicidal, of course, the patient needs to be in a psychiatric facility. If the patient is not suicidal, then is it safe for you to prescribe medications so that their depression gets better? As far as the pharmacotherapy, you can either use SSRIs or tricyclics or monoamine oxidase inhibitors, or also ECT as a last resort. I will discuss the antidepressant medications in greater detail when I go over the psychopharmacology chapter. But because of the safety, not the efficacy, the drugs of choice for the treatment for depression will always be the SSRIs. Why? Because they're cleaner, patients like them, they're more likely to comply. So a happy patient is a patient that takes the medicine because they're not having many side effects. An ECT is used only when the patient is severely suicidal, when you do not have the time to wait 2, 4, 6 weeks for the antidepressants to work. Psychotherapy can also be used, as well as cognitive therapy for the treatment of depression. Now, there are numerous differential diagnoses for major depression. From a medical point of view, the most common reason, not the most common reason, but the most common differential is thyroid disease. Patients who have hypothyroidism look like they're depressed. Patients who have hyperthyroidism look like they have bipolar disorder. So we want to make sure that you check the TSH. Make sure that this person doesn't have anything else that could go with the depression. For example, like Parkinson's. If they're elderly, make sure they do not have dementia or any kind of pseudodementia. Make sure they don't have any strokes. They don't have any tumors if this depression is occurring later on in life. Make sure that this is not due to any kind of loss. For example, patients with grief, you have to differentiate that from depression. Make sure it's not a type of drug withdrawal. For example, patients who are in cocaine withdrawal, they look like they're depressed. So a good history is what will determine whether or not they have cocaine withdrawal or major depression.